Morning, everyone. Sorry, I forgot the music this morning. I was busy queuing up a photo and then a reference. I was like, oh, I've got to get the reference for it before I put it on. And I was like, oh my god, I've only got 2 seconds to go. So here we go. A little bit of it. There you go, done. Welcome back, everybody. Hopefully you're all doing good. Everything looks okay from my end. If you want to drop a message in the comments box, if you are with us live, that would be great. And perfect. Morning, Becky. Good morning. Right then, I know we're now live. So where are we at? We finished with the anterior thigh last time, so we were looking at the psoas iliacus, and we also looked at the medial thigh as well, I think, and we did the adductors as well. So this time we're going to finish off the muscles on the front of the thighs. So there's only one more to go, and then we're looking at the hamstrings. So posterior thigh, and then we will have a look at common pathologies for the muscles of the hip. So that's the plan for today. That was the picture I was queuing up and the reference. There we go. They shouldn't be on that slide. Never mind. Let me just get rid of those. There we go. It was at that point I was like, second to go. Right, let's get rid of that. Cool. So yeah, so a little bit of a recap from last time. So we had a look at rectus femoris on the front of the thigh, and the reason why we included it, even though we included it on the hip as well, on the knee as well, is because it crosses the hip and the knee. So we were talking about how it's one of the most common muscles in the anterior thigh to get injured, because it crosses two joints. So you've got two actions at once. Usually have issues around the musculotendinous junction, so around this area here or down here. You can obviously get muscle belly tears as well, but usually it's around that area there. And then obviously on the insertion as well, you can get tendinopathic issues. It's not as common as some of the other areas we're going to look at today, but it is possible. Okay, anything with a tendon, you can get tendinopathy issues. So yeah, we looked at that. We then looked at the psoas and how deep this was, and we talked about the possibility of palpating it being very, very limited, or being specific for the palpation anyway. And talked about if you're doing a treatment or an exercise, and then you have an outcome, we kind of make up a story in the in-between bit. So we go, right, okay, this person is limited in hip extension, so you do a Thomas test and they're a bit restricted. So then I dig my fingers into your belly, thinking that I'm aiming at psoas, and then your knee drops, so that improves hip extension. So therefore, I've released your psoas. And basically, we know that that's not to be the case. We know the outcome is increase in hip extension, but we don't know the mechanisms fully of what the manual therapy did, or what the exercises do, again, targeting specific muscles. So we should keep it simple and just go, right, okay, I'm going to do this exercise and it will improve your hip extension. Don't need to mention individual muscles or anything like that. We just keep it nice and broad, nice and simple. Morning. Hey, Jeremy. Good morning. Good morning. I've just sent you a message, Al, so hopefully you've been able to log on. Cool. So yeah, we were talking about that muscle there, and then we also talked about this one. So this is iliacus, or iliacus, however you want to pronounce it. Quite a broad, flat muscle, this one. Really powerful hip flexor. If we think about the muscles that are really powerful, they're shaped like this one. So the psoas is quite long and slender. I think that was somebody's mentioned that's one of the derivatives of the word as well. So yeah, this one is has got a much better mechanical advantage to bring about hip flexion than the psoas has. Because if you have a look at the psoas, it attaches to your lumbar spine as well. So this moves, all of the lumbar vertebrae move, plus we've got movement at the hip here. So we've got a stabilization action that has to happen here so that we can generate force for the psoas into hip flexion, which obviously will happen. But this one just attaches to your pelvis and then down onto the lesser trochanter. So much more likely to produce a significant amount of force. So I would argue that this is probably one of the most important hip flexors out of the two for isolation of a movement. Then we didn't look at this one, so we're going to cover this one as well. So this is your sartorius. So we've got, I think this is wrong actually. So it's ASIS it attaches to, not AIIS, apologies. So it's your anterior superior iliac spine, which is the kind of knobbly bits at the front of your pelvis, and really well developed in footballers because of the action of kicking a ball. And obviously you can see it really well on a bodybuilder because they've got zero body fat. So it's the muscle that crosses over the thigh from the outside to the inside. So again, a nice long slender muscle. Because it crosses two joints, the thing is with this one, because it's at a bit of an angle, it's not very good at producing force. So it wouldn't be one of your prime movers. It would be one of your assisting muscles, so a synergistic muscle. And because if you have a look at the actions, look, we've got flexion and medial rotation of the knee. Okay, so it's going to act on the knee because it crosses the knee joint. Flexion, abduction, so taking the leg out to the side, and lateral rotation of the hip. Okay, so but it's, I mean, the moment arm on that is really small, so it's not going to be able to generate the forces. It's not the main mover of those movements, although it does do those movements. We'll have a look at the nerve supply over the next couple of weeks, okay? But just to let you know, this one is femoral nerve, which is the nerve that runs down the front of your thigh, and the arterial supply is from the femoral artery. And we've had a look at these two when we were looking at the femoral triangle a couple of weeks ago, but we're going to explore those a bit more over the next couple of weeks. So that's your sartorius, and this is what it looks like. So this one is paired with gracilis, which we've already had a look at. So let's have a look at these. Excuse me. Okay, so just pause that there, move me out of the way. So front of the thigh, this is a right thigh. There's your kneecap. This muscle here is your rectus femoris. This one here is your vastus medialis, sometimes called VMO. So vastus medialis oblique, covered that during the knee. This one here is your vastus lateralis. Okay, the reason why we covered the vastus muscles on the knee and not the hip is because they don't cross the hip. Okay, so although they act on the front of the thigh, because of their attachment points, they don't do anything to the hip. Okay, so all they do is extend the knee, and that's it. So that's that one and that one. This one we look at on the hip because it attaches up here and it crosses the hip. So that's on the AIIS, which is what it said on the sartorius, but that was wrong. Here's your sartorius here. Okay, so it's really superficial. Starts out, sweeps across, and then comes in and attaches down here on the tibia. Okay, so that's that one. So we've got sartorius is in the anterior compartment of the thigh, so at the front, and then gracilis is in the medial compartment on the inside. Okay, so that's and there's gracilis just there. So we're going to have a look at those in a bit more detail now. So there's your sartorius. There's your VMO. Okay, so all of these structures here, we had a look at these over the last couple of weeks. So these are your adductor muscles. So there's your gracilis just there. So the attachment point on your pubic bone. Sometimes that can be involved in what we call sportsman's hernias. So where you get an irritation of the attachment in the pubic region. And then there's the attachment point on the tibia. Okay, just down here. So we call it the pes anserine area because it looks like a goose's foot. So it's kind of webbed. Although whenever I've looked at it in the labs, it looks nothing like a goose's foot. So, but there we go. Someone somewhere must have had and seen it. So SGT, so this attachment point just here is your sartorius, gracilis, and semitendinosus. Okay, we did cover that in great detail in the knee. Okay, so that was the last muscle on the front. And then we're going to have a look at the around the posterior aspect of the thigh. So going to look at your hamstrings. So these obviously act on the hip and move the hip into extension. That's one of its main jobs. Again, these are biarticular muscles, so they've got they cross over two joints. So they act on the hip and they act on the knee as well because of where they insert. Yeah, again, likely to get injured, but usually it's the biceps femoris that is the likely one that gets injured. We'll talk about which one's which in a sec. So we've got four hamstring muscles on the back. One is split into two, so there's a long head and a short head. This one is just one big muscle. And if we break down the name, so we've got semimembranosus, so it's half membrane. So when we have a look at it on the images in a second, you'll see that there's lots of white in the semimembranosus, which is the membrane section of it, and very little reddy bits, which are the muscle bits. Okay, so really long, flat membrane, and then there's a bit of a muscle belly in it. So that's why it's called semimembranosus. This one is on the inside of the back of your leg. Okay, so where your inner thigh muscles are, just around the back of that's where your semimembranosus is. And then semitendinosus is half, so semi-tendon. Okay, so we've got a really long tendon here, and you'll see that on the video, but also you'll be able to feel this one. So the way to remember the order of these, so they're both on the inside, and the tendinosus is on top, so it's the one that you can feel. So if you have a feel at the back of your knee with your knee bent, and then just relax your leg, and then just scrape your heel backwards as if you're scraping dog muck off your shoe, and then feel the tendon on the inside of your back of your knee. So the one that's really prominent, that is your semitendinosus tendon. Okay, and you can feel that really, really easily. And then if you feel that, and then just just drop off it and like move around to the inside again, and then you'll feel another tendon underneath it, and that's your semimembranosus tendon. Okay, and they're really close to each other. So you feel one is semitendinosus, that's on top, and then just slide off and underneath, and then that's semimembranosus. Okay, so that's those two. And then the last one, because these are all grouped together, is your biceps femoris. So if you think about it, we've got a bicep muscle in our arm, and biceps from cephalic or cephalic is two heads. Okay, so biceps means two heads. So biceps femoris is two heads femur. Yeah, so that's where the name comes from. Yes, we've got a long head which attaches onto your sitting bones, so your ischial tuberosity up here. Then it joins in with this short head, which is just tucked behind there. Okay, and your short head is on the linea aspera, and we talked about that a few weeks ago. So there's a raised line on the back of the femur where loads of muscles attach onto, and your short head of biceps femoris attaches onto there. Okay, and then it comes all the way down and attaches onto your fibula, just down here. Okay, so head of fibula is your distal attachment point, so the one furthest away. Again, it crosses two joints apart from your short head. So the long head is the one that is likely to get injured. Okay, so because it crosses two joints and has two actions. The short head is less likely to get injured because it attaches onto the femur and then just acts on the knee, and that's all it does. Okay, so but they both join together. They've got a conjoined tendon. So let's have a look at those. So this is a general look at the hamstring, so quite a broad look, and then we'll go a bit more specific and a bit more detail. Okay, so this is the inside. So this is the inside of a right leg. So tendinosis on top. There's the tendon just there. Membranosis just underneath. They all look like one. Let me just go back a little bit. There we go. So yeah, semimembranosis, half membrane, semitendinosis, half tendon. They're on the inside of the back of your thigh. So this is the back of a right leg. That's the back of the knee just there. All this yellow stuff, that's all fat. So wherever there's a space in the body, it's usually just filled with fat. Okay, so fatty tissue at the back there. It's a good protector. You've got some important structures at the back of the knee, so the blood supply and the nerve supply that you want to protect, because you see that the muscles run either side. Okay, so they split. So the back of the knee, the popliteal fossa is exposed, so it's covered with fat, and then obviously your skin to protect it. So you've got the tendinosis just here. Okay, so you can just about make out where it turns into a tendon. And then underneath it, can you see that one just there that runs alongside it? That one is your semimembranosis. Okay, cool. All right, let's have a look at these. So attachment points on the ischial tuberosity, so your sit bones. And then there's the attachment of the semimembranosis on the back of the tibia, tendinosis on the tibia itself. There we go. There's a linea aspera. Ooh, just pause that. Hold on. Just go a bit slower. So on the outside, so this bit here, so semitendinosis and membranosis were here. So this is the inside of your leg, back of a right leg. This one here, this is biceps femoris. Okay, so two-headed femur, and you've got your short head and long head both joining in together there. So there's your biceps, two heads, ischial tuberosity, linea aspera are your two attachments, and then down onto the fibular head just there. Okay, cool. So that was your intro. Here's a bit more of a detailed look at those. Okay, just go back a second. Okay, just pause that there. Okay, so back of a right knee again, right leg again. That bit there is your greater trochanter. Okay, so we've been looking at that over the last couple of weeks. You've got glute muscles up here. These are all the hip rotator muscles just in here. There's your ischial tuberosity, so your sit bones. And then you can see the muscles coming down here. There's nothing over the top of them yet. So that looks like a ductor magnus to me because it's quite a big muscle there. And then let's have a look. There you go. So those are your hamstrings being laid on top. Yeah. So ischial tuberosity there. So sit bones. So the most superficial of the sit bone muscles. Okay, just up here. And then you can see where they split. So two muscles go this way, and one from the ischial tuberosity goes this way, and then it's joined by the short head just underneath it, just there. Okay, so these are all your hamstrings all together. So yeah, semimembranosis and tendinosis are medial, so on the inside, and biceps lateral on the outside. Okay, so there's your membranosis and tendinosis. And here we go. Okay, cool. So this is a really nice image. So this is what you see in the books. Okay, so really, really long flat membrane and then a bit of a muscle belly. Yeah, and this is a example in real life. So there's the membrane, and then this is the muscle belly of it here. Okay, so it's kind of like it's fragmented. Okay, so there's bits of connective tissue mixed in with the muscle, and again, that's why it's given its name, because it is membranous. Okay, it does look like a membrane. So long flat membrane there, ischial tuberosity attachment, and then down onto the back of the tibia. Okay, so it acts on both the hip and the knee. And then this is semitendinosus. So this lies over the top. There we go. Tendinosis is on top. So it's more superficial. You can feel this one easier. And that's why when you feel the back of the knee, that's the first one that you feel, because it's closer to the skin. Okay. So that's this one just here. And then let's follow it down. And then there's the really long tendon. There, look. Okay, so it's very different to the other one. The other one's quite flat. This one's more cord-like, and then it attaches lower down here. Yeah, and that's your pezanserine, the goose's foot area, sartorius gracilis semitendinosus, attaching onto there. Cool. And then the last one, biceps femoris on the outside, and it's got two heads. So you can see all of those attaching on the ischial tuberosity, and then it's coming down here. Short head joins in, and you can see the conjoined tendon. So that's where long head attaches. And then short head attaches here. Okay, so quite a broad attachment on the back of the thigh, on the back of the femur there. And then they both join together. So you can see them joining together here, two heads joining. And then there's your tendon for biceps. And then it merges onto the fibular head just there. Okay, cool. So just on that biceps one, if you do that scrape thing again and feel the inside of your back of your knee, you can feel semitendinosus. Now, if you feel on the outside of the back of the knee, and you'll feel another really big tendon there, quite thick, that one's your biceps femoris tendon. So those are really easy to feel. They're really superficial at the back of the knee. Harder to palpate ischial tuberosity and distinguish between the two. Or three of them where they attach. Yeah, because they all kind of merge in together. But I'll show you that in a second. Okay, cool. Right. So see if there's any questions. No, that's all good. Just smiling at Tristan's reference to Red Dwarf. Okay, let's have a look at this one. Okay. So what I wanted to do was bring in a little bit of pathology for the muscles. So we've covered all the muscles now, and we've talked a little bit about when things go wrong with muscles. Obviously, muscles can tear, and they can be bruised and whatever. But a common thing you'll hear, especially around the hip region, is to do with tendon problems. Okay, so tendinopathies, you'll hear that quite a lot. So we're going to have a look at tendinopathies and what causes them. Okay, and what the theories are behind what causes them. So let's have a look at that. So glute tendon is a really common, or glute tendinopathy is a really common pathology. Okay, it's we talked about this a little while ago, where if a lot of them, the muscles attach onto the greater trochanter. Some of them attach, like glute maximus attaches onto the IT band or onto the gluteal tuberosity just down here. But your glute minimus and medius attach onto the greater trochanter. And previously, any kind of lateral hip pain, so problems with the greater trochanter, and you go to the GP or whoever, and they would say you had a bursitis. We looked at bursitis a few weeks ago, and there's about 7 bursa around that region. And so it's like, which bursa is the problem? So you can't be very specific. But also there's loads of muscles attaching into there as well. So you can't be really specific with which muscles causing the problem. So it's what we tend to call it now is a greater trochanteric pain syndrome. And I mentioned this before. So anything around the greater trochanter, because it's hard to be specific, it's a GTPS. Okay. And because as well, generally the treatment for the region is the same. Okay, so you would do similar kind of things, because it's mainly tendon issues that cause the potential symptoms. Okay, so these are all the muscles that we've been looking at over the last few weeks, and then this is where they attach. And I was saying that sometimes gluteal tendinopathies are really sore around here, so the back of the thigh, not necessarily on the greater trochanter. So if we think about a glute tendon problem, they can be up here, okay, around the iliac crest, because obviously there's a tendon that's going to attach onto that bit. They can be here, so where glute minimus is, so just above the greater trochanter, but on the pelvis bone, right on your ilium, rather than at the greater trochanter, or around the back here where your glute max attaches. So see all the tendon there, yeah. So they could be there as well, and I find a lot of issues with glute tendons here, and especially here. Okay, the greater trochanter sometimes, but I don't know. It just not so much, right? But probably out there. But I don't know. I just tend to because I examine everything, but it tends to be here and on the pelvis that where the symptoms are. Okay, and the really interesting thing is the symptoms from that region mimic sciatica. So if you have a problem up here, and if you push into these areas here and give it a good old prod and see which bits are sore, sometimes they'll get referred pain down in the side of their ankle and into their foot. And it looks like an L5 problem, disc problem. And again, it's often misdiagnosed as sciatica, and actually it's a gluteal problem. So it's something to look out for, okay? Because sciatica just means pain down the back of the leg. Yeah, it doesn't mean it's a nerve problem. But pain down the back of the leg can be coming from here as a referral. Okay, and you can reproduce it. So yeah, you stick your thumb in, and if it radiates and goes down the leg, and it reproduces their symptoms, then it's potentially a glute problem, a glute tendon problem. Now the attachments on the greater trochanter, this is quite interesting. So if you have a look around here, we've got glute medius just here, okay, so around the back there. We've got the glute minimus towards the front, okay, just there. Long head of glute minimus, so it's split into two heads, and then the piriformis attaches there, but there's a bald spot in the middle where there's no attachments. Okay, so it's usually this kind of ring around the greater trochanter that is tender, and again, usually, and obviously you have to have a good old feel around, but usually it's the back that's tender rather than the front section of the greater trochanter. Okay, so leading potentially more to a glute medius issue potentially. But it could be piriformis, or it could be your obturator muscles as well. Okay, so it depends. But yeah, just thought that was quite interesting that there's a missing bit in the middle where nothing attaches. Okay, so there we go. So let's have a look at gluteal tendinopathies then. So this is from, there's a couple of things here from a lady called Alison Grimaldi. And she's a kind of leading researcher on gluteal tendinopathies, I think mainly lower limb tendinopathies. So greater trochanteric pain syndrome, or GTPS, is a common cause of lateral hip pain, seen more commonly in females between the ages of 40 and 60. And again, there's often hormonal changes during that age period that make women more susceptible to these particular tendinopathies or lateral hip pain. GTPS is the cause of hip pain in 10 to 20% of patients presenting with hip pain to primary care, with an incident of 1.8 patients per 1,000 per year. So it's quite common, okay? It's a really common issue. And yeah, it was just passed off previously as a bursitis. So yeah, this is from Grimaldi. She's got this. I think this is free. So if you search for gluteal tendinopathy, a review of mechanisms, you should be able to come up with a PDF. So we've got tendinopathy of the glute medius and glute minimus tendons is now recognised as a primary local source of lateral hip pain. Okay, so it's quite well documented. Gluteal tendinopathy is the most prevalent lower limb tendinopathy, substantially impacting quality of life. It is horrible. I've had it. It is not nice. It lasts for bloody ages. So one of the things you need to warn people is this can last for about 4 months. Okay. Yeah, it's and that can be just wearing. Okay. I tell you, it was. But this is the reason why it happens. And this is the interesting thing with Alison's work is we've got a nice little theory about the mechanisms. So the way that I explain this to patients is that tendons like to be in a balance, like everything else in the body, and like to be in that Goldilocks zone of not too much and not too little. Okay. So if we have these things called TIMPs, so tissue inhibitor of metalloproteinases, I was a bit worried about pronouncing that one. So these are MMPs, and then we've got TIMPs, TIMPs, and then we've got MMPs, which are matrix metalloproteinases. So if you've got MMPs, these are enzymes, okay, and if you have a proliferation of these MMPs, these are pro-catabolic, so they break down tissue. Okay, so these are enzymes that will break down your tendon tissue. There are cytokines. So the cytokines basically are signalers, protein signalers to start the inflammatory process. So the tissue healing process. But sometimes they can be catabolic. So it breaks down tissue because there's too much inflammation. Or you can have pro-anabolic cytokines which build. Okay, so like anabolic steroids. Yeah, so we've got anabolic cytokines and then pro-catabolic cytokines. So if you, this is load, okay, down the bottom here. So these two link together. So if you're in the middle there and you've got normal amounts of load, then what we have is a positive adaptation of the tendon. Okay, so we have more anabolic activity than catabolic. Yeah, and then what happens? Yeah, so we've got an increase in anabolic cytokines, increase in collagen synthesis and turnover. So we get a healthy, adapted tendon. Okay, so this is where we want to be. Yeah, balance is kind of obviously there's an equilibrium between anabolic and catabolic. So if you've got load which is just slightly above normal, then we get this positive adaptation. Now, if you go a bit mental and you do too much exercise, there's a failure to adapt. So we'll get an increase in these MMPs and the pro-catabolic cytokines, the things that break down tendon tissue, and the catabolic effect is greater than the anabolic one. So it's breaking it down faster than it can be built. Okay. And there's an increase in MMPs and catabolic cytokines. So this, we get a degradation of the tendon. All right. And this is where you get a tendinopathy problem. So it doesn't take much to tip it into catabolic. But then interestingly, we've got this where you have under normal activity, so less than normal. And now we've got a stress deprivation and an increase in catabolic activity. So if you do nothing, your tendon starts to break down. If you do too much, your tendon starts to break down. Okay, so we need to find this happy balance in the middle where we're skirting between homeostasis and positive adaptation. And that comes with programming. Okay, so if you're undertaking load, whatever it is, whether it's work or activity, you need to gradually build that activity up. Okay, this is one of the biggest things to explain to people when they've got tendon problems, because they go, well, I've got a slide for it. Hold on, I'm jumping ahead. Okay, so if we've got a net anabolic effect, so we're having an increase in the building of the tendon. So a load is applied to a tendon longitudinally, okay, so along it to its collagen fibers, or perpendicular, so across it to the line of the fibre, so it's being compressed. The latter particularly at its bony enthesis, so where the bone attaches, the tendon attaches to the bone, that's called the enthesis. So a load may be applied to a tendon either along it or across it, okay, with a stretch or a load through it. So tensile loads may be applied by actively, so with muscle contractions, so you're doing work, or passively via stretching. Tendon loads will be particularly high when the muscle is active. So you do get some adaptation with stretching, but it will take you blooming ages. Okay, but if you actively load the muscle, then that's where you get the maximum adaptation to the tendon. The tendon's lengthening at the same time. So yeah, especially then. So in eccentric contractions, so where the muscle's being lengthened, so like in sprinting, that's maximal longitudinal tensile load. Okay, so along the muscle, the tensile load is really, really high. So you'll get maximum adaptation unless you do too much. Okay, so graduated increase in tensile load with adequate recovery and adaptation time induces a net anabolic effect. So it will adapt. Okay, and then we'll get a subsequent increase in the load bearing capacity of the tendon. It will be able to tolerate more. Okay, so however, a rapid increase in the intensity or frequency may lead to failure to adapt and then a catabolic effect. So that was on the right hand side of that chart that we just saw. So that's just tipping over from normal adaptation into when things start to break down. Then what we've got is your couch potato, and this is what I hear quite a lot. I didn't even do anything. Okay, so I didn't even do anything to my tendon, and I don't know, I've not exercised for ages or whatever. That's a problem as well. Okay, so if you don't do anything, your tendon breaks down. So a net catabolic effect also results from lack of tensile load, so a stress deprivation. And at a cellular level, we've got stress deprivation and compression induces an expression of catabolic enzymes. So these are the things that start to eat away at your tendon. They break down type 1 collagen, increase tenocyte expression of the large proteoglycans, which basically cleave apart, so they pull apart collagen fibers. So doing nothing breaks your tendon down. Okay. Matrix degradation and changes in tenocyte behavior reduces the load bearing capacity and then predisposes you to injury at relatively low tensile loads. So if you've done nothing for ages and then you've just been inspired by yesterday's marathon and you think, right, I'm going to go and do the park run on Saturday, 5K is a long way if you haven't done anything for ages. So you're more likely to get a problem. Okay. So hopefully that makes sense. And then I love this diagram. It's brilliant. This kind of explains everything. This is by Jill Cook and Craig Purdom back in 2009. So it's been around for a while. I'll quickly explain this because of just looking at the time. So we've got normal tendon here. This is where we want to be. We optimize the load, it adapts, and we get stronger. Okay, and then we've got normal tendon still. We optimize the load, it adapts, we get stronger. So we want to stay in this loop. Okay, this is where we want to be. However, if then all of a sudden you decide instead of doing 10 miles a week, you're going to do 15 or 20, we've then got an excessive increase in load. Okay, so then the tendon will become reactive. If we continue down this path, it may then go into disrepair and then become degenerative. Okay, so if we don't catch it early and reverse the issues, then you're going to have problems. Okay, so what we want to do is someone comes in with a gluteal tendinopathy and they've been doing a little bit too much activity because you've asked them what they've been doing or looked at their Strava or whatever it is. They're in this reactive phase, so then we modify their load and then it becomes normal again, and then we get back in this loop again. Yeah, so that's what we want to do. The lower you go down here, the harder it is to get back. Yeah, so if we can catch it early, brilliant. Then we've got a problem here where I haven't done anything for ages, so I've been sedentary. We've got a mechanically weaker tendon, and then normal loads make it reactive. Okay, so and we want to stay out of this loop. Yeah, so if you're sedentary or have been sedentary for a while, and you do too much, not even too much, just what's considered normal, especially if you've had someone who's used to exercising, maybe they've been injured and then they just think, right, I'm going to go back to where I left, and they don't build it up again. That's when you get this kind of problem. So yeah, instead of being sedentary, we want to optimally load the tendon, which is weird for them to get their head around, because they think, well, if it's hurting, so why would I want to do anything? Well, actually, if you do stuff, it eases the problem, because your tendon will adapt. So that takes a bit of convincing. Okay, so if they've been sedentary, then we need to load them optimally and then back into this loop again. Okay, so that's a nice diagram to show them. Yeah. That's a good question. So we never really want to prescribe rest, not for too long. Sometimes you do need to rest, but you don't want to do it for too long. And the problem is with all of this is nobody knows what too long is. Nobody knows what optimal load is. The only person who's going to know is the person that is doing the exercises or whatever it is, and then monitoring how they respond. And I'm quite open and honest with people about that. I say, look, this is what we need to do, and I'm going to give you these exercises, but I don't know whether it's going to cause a flare up for you. It may do, okay? And if it does, we just need to adapt it. So just to let you know, this might happen, okay? Because we haven't got a clue. We haven't got a clue what normal is and what optimal is. So we have to err on the side of caution, but then gradually introduce stuff, yeah, and then hopefully stay in this loop here. But the key thing I think is that it's not just to do with exercise. If you have a look here, we've got individual factors as well. So there may be stuff going on in their life that's really stressful. They may not be eating very well at the moment, so their nutrition is poor. Their sleep might be disturbed, so that might be affecting how they recover. Yeah, so it may not just be the stuff that's going on in the gym or on the track or whatever it is they're doing. You have to look at their whole lifestyle, and that can be affecting their recovery. Okay. Yeah, working within the ranges that they can tolerate. Yeah, exactly. Yeah, that's perfect. Let's have a look at this. Sorry, Becky. So hence why people tend to be encouraged to load the body more. So post MSK. Yeah, exactly. Yeah. Yeah. Referencing the lack of load being negative on the tissues. Yeah, definitely. So, and that's often a surprise for people. So they'll have a knee operation or a hip operation. They'll go, blimey, I was out of bed the same day, and they're expecting to be laid up for a couple of weeks. Yeah, they will get you up and out of that bed straight away. You need to load the tissue, because otherwise you're going to get degradation of the soft tissue. Yeah, definitely. It's via the nervous system, basically, Eleanor. So because of the nerves that's where the gluteal sensory nerves come from in the lower back, if you push on there, then when they go back into the spinal cord, the brain in its wisdom thinks that it's come from other sources that share that same pathway. So it's classic referred pain. Okay, so yeah, it's really, really common, and you know because you can reproduce the symptoms. So I had it last week actually with someone with a gluteal problem. They'd been to the doctor and said they got sciatica. I checked all their lower back. The lower back's fine. No problems with reflexes or strength or anything like that. I was using shockwave, so I put shockwave over the hip, and had it on this certain point. I think it was around glute minimus on the pelvis, and there was a specific point that was really sore, and it immediately reproduced her symptoms down her leg, and those were the symptoms that she had. So I'm working on the assumption that it's a glute tendinopathy problem. Yeah. So, but yeah, it's to do with the nervous system, and it's not the same, but it's the best way to explain it. It's like when you have a heart attack and you don't feel it in your heart, you feel it down your arm. Yeah. There's nothing wrong with your arm, but the symptoms you feel down the arm, but actually the problem is in the heart, and it's because of shared nerve pathways from the neck. Okay, so the body in its wisdom, again, with a heart attack, it goes, it can't be coming from there, it must be coming from there, so it makes your arm hurt. Okay, so that's why that happens. Cool, no probs. Perfect. So yeah, we've got a couple of I planned for a little bit more, but time's run out. I could talk about tendinopathies all day. We've got some hamstring tendinopathy stuff to do as well, and I'll show you some things about that next week, and then we'll move on to the nerves around the pelvis. Okay, so we're going to do nerves and blood supply and finish off the tendinopathies. Okay, cool. Guys, have a good week. That flew by today. Hopefully that was interesting. And yeah, if any questions in the group, give me a shout. And I'll try to answer them next week. See you then.